Chapter 30, the high-risk newborn, acquired and congenital. Transient tachypnea of the newborn, TTN. Infants with transient tachypnea of the newborn develops rapid respiration soon after birth and is caused by inadequate absorption of the lung fluid. It will resolve within 24 to 72 hours. Respiratory rate typically is between 60 and 120 breaths per minute. Retractions, nasal flaring, and grunting and mild cyanosis are present. Treatment is geared towards supportive measures and may include oxygen and gavage feedings while respirations are high. Eating is hard work for infants, so if they're already working hard to breathe, we don't want to make it harder by doing oral feedings. Nursing considerations include notifying the provider of the findings and carrying out all orders. The same type of care will be provided as you would for a preterm infant experiencing respiratory issues. Meconium aspiration syndrome occurs when there's meconium fluid and the infant aspirates that fluid during the labor or at birth. Manifestations include signs of respiratory distress, which can be mild or severe, which can be urticapnia, retractions, nasal flaring, grunting, and rales. The infant's nails, cord, and skin may be stained with meconium. Therapeutic management include warmed, humidified oxygen as needed. Some may require mechanical ventilation as well. Nursing considerations include notifying the NICU of the birth if there is one in the facility. Many times they will have their own nurses come down for delivery if there is meconium fluid. Good assessment of respiratory status is needed, and if problems occur, following treatment measures for an infant displaying signs of respiratory distress. Please refer back to the earlier podcast on the types of jaundice. The most common cause of pathologic jaundice is a hemolytic disease of the newborn stemming from incompatibility of the blood between the mom and the fetus. The main cause is Rh incompatibility. This is where the Rh negative mom forms antibodies when the Rh positive blood from the fetus enters her circulation. The antibodies can cross the placenta and destroy the fetal red blood cells. When excessive hemolysis occurs, it causes erythroblastosis fetalis. Issues can occur with an ABO incompatibility, but the destruction is less. Other causes of non-physiological jaundice include infection, hypothyroidism, polycythemia. Infants of diabetic mothers are also at risk, and so are macrosomia infants. Also, any conditions that can cause destructions of the erythrocytes or impairment of the liver can cause an increase in the bilirubin levels. Therapeutic management includes prevention of bilirubin encephalopathy and kernicterus. This can be done by identifying issues during the prenatal period. A blood draw for the Coombs test will identify the presence of antibodies that could be present. Nurses will monitor for jaundice if it's worsening. They can also perform a transcutaneous bilirubin level. This uses a bilimeter that is pressed on the infant's forehead or sternum to get a bilirubin level. This is a screening tool, so if it registers as a higher level, they'll do a blood draw for a more accurate bilirubin level. Phototherapy is the most common treatment for jaundice. There are several ways this can be provided. There are billy blankets that wrap around the infant and is used many times in the home setting as well as a hospital. They can use a billy bed, which the infant lies on, and there are overhead billy lights. The billy bed and overhead lights have fluorescent bulbs that assist in breaking down the bilirubin so it can be excreted out. The lights can be damaging, so eyes or a mask or goggles need to be worn during these therapies. The billy blanket uses a fiber optic lighting and not damaging to the eyes. As much of the skin needs to be exposed as possible besides the diaper area. Side effects of the stools can include frequent loose green stools. These stools can be hard on the skin, so monitoring for skin breakdown, which will be like your diaper rash, is crucial. The stools also cause fluid loss, so monitoring for signs of dehydration is needed. Bilirubin checks will be performed to monitor the effectiveness of the treatment. Exchange transfusions are not needed very often, but will be performed if the levels continue to climb in spite of the treatment measures. When an infant has hyperbilirubinemia, you must assess for the level of jaundice at least every 8 hours. You can do this by blanching the skin over the sternum and see how the skin blanches to see if there's jaundice in that area. Jaundice moves down the body, so if it's only facial jaundice, then it's not as severe as if they have it all the way down the trunk as well. Also, the TCB or blood draws will be needed for accurate levels. If they are receiving phototherapy, Ensure that mask or goggles are in place as needed. Assess skin conditions as well, noting any areas of breakdown. Assess infant temperatures to be sure they are maintaining. Watch for signs of dehydration and monitor good eyes and O's. Remember, we want as much of the infant's skin exposed to the lights, so positioning correctly is needed. A big part of educating the parents on the necessity of the lights. Many parents want to hold the infant, and we must allow for some bonding and holding during feedings, but we must educate on the importance of returning to the lights when feeding is done to help enhance the treatment measures. Educate on the importance of feeding and about not skipping feedings. Educate on the importance of keeping the eyes covered when under the lights as well. Sepsis neotorum is a systemic infection from bacteria in the bloodstream. They are susceptible to infection due to their immature immune system. Common causes in sepsis in the newborn include GBS and E. coli. See Safety Alert in the book for signs of sepsis. Therapeutic management includes a CBC. Sepsis will have an increase in the bands, which are those immature neutrophils. They're trying to fight off the infection, but they're not mature enough to do that. They will also have a decreased platelets. A sudden rise or fall in the leukocytes is abnormal as well. The CRP, your C-reactive protein, is elevated in response to the inflammatory process. Blood cultures will be obtained, possibly urine cultures and a lumbar puncture. Blood glucose levels will be monitored as well. This is one time the blood sugar can go high in response to the infection. Treatment will include antibiotics. They usually will do broad spectrum. They may need oxygen or mechanical ventilation. Monitoring fluid balance and electrolyte imbalances. Nursing considerations include assessment for signs to put the infant at risk, which would include maternal infection, the GBS status, prolonged ruptures of membranes, watching for signs of infection also. Prevention of infection includes good hand hygiene, disinfecting equipment between patients, decreasing risk for trauma to the skin. Nurses will provide antibiotics as ordered, and we will support the parents as well. The infant of a diabetic mother faces many risks. Insulin acts as a growth hormone for the fetus, so many times these infants have macrosomia. They can have hypertrophy of the liver, spleen, and heart. All organs except the brain and possibly kidneys are larger than normal. Face is round and body obese. They have poor muscle tone, can become irritable, and have tremors. The biggest therapeutic action that can take place is to have mom control her blood sugar during pregnancy. If the infant is large, being prepared for shoulder dystocia. This infant can have respiratory issues, so preparing for that as well. Nursing considerations include monitoring the infant's glucose levels after delivery per facility protocol. The most common signs of hypoglycemia is jitteriness or tremors, but not all infants will display those. Glucose levels should be at least 40 to 45 milligrams per deciliter per facility policy. These infants should be fed soon after birth to decrease problems. These infants are at risk for respiratory issues, so monitoring for signs of RDS, provide support to parents, and explain the plan of care. Polycythemia is when a hematocrit goes above 65% and hemoglobin levels are greater than 22 grams per deciliter. This will cause the blood to be thicker, which decreases blood flow. This can occur when the fetus produces more erythrocytes, which can occur when a decrease in oxygen in utero occurs. It's more common in LGA, SGA infants, maternal hypertension, diabetes, smoking, or delayed cord clamping. Many times they will not display any manifestations, but may be plethoric, which is ruddy in color. They may have lethargy, irritable, poor tone, and tremors. Treatment is mainly supportive. Being sure proper hydration is occurring will be needed, and possible partial transfusion may be needed if hematocrit goes above 70%. Nursing considerations include monitoring bilirubin levels and monitoring I's and O's to ensure of adequate hydration. Any drug exposure to the fetus can be harmful. Most drugs cross the placental barrier. Neonatal abstinence syndrome, known as NAS, is a disorder in which neonates demonstrate signs of drug withdrawal from in utero drug exposure. Most signs of withdrawal will take place 8 to 48 hours after birth. Most will require pharmacotherapy for withdrawal symptoms. If pharmacotherapy is needed, they will often be in the NICU for closer monitoring. These infants need to be rocked and have a quiet and calm atmosphere. Most NICUs have a special nursery just for withdrawal babies. It is sad that a nursery is needed just for that, but it is, and so many times these nurseries are full and cannot accept more babies. Many times we do not know what the infant has been exposed to during utero. Careful assessment for signs of intrauterine drug exposure is needed. See the safety alert box in your book for these. Most are hard to console, irritable, have tremors, have excessive sucking, excoriation of the skin. Therapeutic management consists of managing the problems that can occur with complications. Medications commonly used to help with withdrawal symptoms include oral morphine, methadone, and phenobarbital. Gavage or IV feedings may be needed because they cannot coordinate their sucking and swallowing. Nursing considerations include assessing for these complications I just mentioned, monitoring their feeding behaviors. They may need a higher K-Cal formula to meet their nutritional needs. We'll assess for tremors, muscle tone, and keep a quiet environment, and reducing the stimuli can help with these. The environment will have very few lights and will be quiet zone. A calm approach is needed. Swaddling helps provide comfort, as does rocking. A pacifier may also provide comfort by providing non-nutritive sucking. The infant may scratch itself due to increased activity and irritability, so covering the hands with mittens can help. We want to promote bonding with whomever will be caring for the infant. The parents may not be allowed, so it could be a foster parent or other relative. If it is the birth mom, we need to document how often they visit, their behavior, and interaction with the infant as well. As nurses, we need to make the mother feel welcome and treat her with respect. This may be hard at times when we see how the infant is behaving. We want to build a trusting relationship with her. We need to provide the same education to her as any other postpartum mom. Some drugs will cross into the breast milk, so some may not be able to breastfeed. Phenylketonuria is also known as PKU and is a genetic disorder that causes central nervous system injury from toxic levels of the amino acid phenylalanine in the blood. Manifestations of the untreated disease starts with digestive problems and vomiting, but will progress to seizures, musty odor to the urine, and intellectual impairment. Older children can have eczema, hypertonia, hyperactive behavior, and hypopigmentation of the hair, skin, and irises. Therapeutic management includes a diet low in phenylalanine. A small amount is allowed because it's necessary amino acid. This is a lifelong dietary plan. It's important for women who have PKU to follow the diet precisely before becoming pregnant and continue throughout pregnancy to reduce the risk of fetal anomalies. Nursing considerations include being sure all infants have their newborn screening tests done prior to discharge from the hospital. This is one of the main tests that is detected. In fact, the test used to be called PKU test because that was what it was testing for. Now the newborn screening covers over 50 metabolic disorders. The nurse will also help families be compliant to the diet if the infant is diagnosed with it.